the upcoming World Patient Safety Day that is going to be on the 17th of September 2023 to be celebrated across the globe. So my name is Eric Kitangala. I work with the Ministry of Health and also support a lot of patient safety initiatives across board from the ministry, private sector, and also partners. So for this day, we are welcoming you to this webinar, whereby it's graciously been partnered with Kenyatta National Hospital, University of Nairobi, and also co-sponsored by WHO, Nyeri County Government, and Society for Quality of Health, Mater Hospital, Kenya Association of Pharmaceutical Industry, Introspective, the Aga Khan Hospital, Farm Access, and Safe Care. So all these things are being coordinated under the Ministry of Health, and I take this opportunity to welcome you for this webinar. So before we start off, we'll say a short word of prayer, and then I will introduce the panelists, and then we can start off the webinar. So let's give thanks. Father, we thank you for this day that you've given us. Thank you because we are here to celebrate and also just to get information about our wellness on this upcoming World Patient Safety Day. Open up our minds so that we may be able to understand and grasp all the deliberations as may be delivered. We thank you. We pray this short prayer in Jesus' name, amen. So thank you very much and welcome everybody. So we have three panelists who are going to be taking us through this discussion. So one thing that you can do, I will allow you to be putting in your questions on the chat box, so that now we can respond to the questions as we go through the webinar with the experts who are on board. So sorry, can you hear me? I got distracted a little bit.
Yes, I can hear you.
Okay. Yeah, so through the Ministry of Health, they've made it possible. So I will introduce our panelists. Will be Thomas Gashuki, who is the head of Quality Assurance Division of actually the Division of Quality Assurance in the Ministry of Health, and then also Daniel Kiura and Dr. Stella Mushemi. But as we start, we'll get opening remarks from Mr. Thomas Gashuki. So Thomas Gashuki, are you in the house? Thomas Gashuki, head of division.
I can't find him. So
okay.
Let me try and see whether we can get him.
Oh, and Jennifer? And welcome.
Thank you, Eric, for inviting me. And good afternoon, very good afternoon to all the other panelists and those attending this webinar. So I am here to talk about building a culture of safety to minimize patient harm. As you've been told, other than being in the Mater Hospital, I'm also a member of the Society of Quality Healthcare Kenya, which is one of the sponsors, which that council together with Rhoda Kalondo, and she will be co-paneling with me on this presentation. So to set the stage for this discussion, I wanted to take us 12 years back to an incident that will help us to appreciate what is, where are we coming from, and how are we going to use this scenario to teach us about developing a safety culture and sustaining it. So this incident is actually from the aviation industry. Kenya Airways Flight 570 is having a mission to move from Abidjan in Cote d'Ivoire to Nairobi through Douala in Cameroon. This is very similar to what happens to us in the health space, whether we are pharmacists, whether we are nurses, doctors, and so on. We have this client, like just in an aircraft, the passenger, we have our patient. This is a patient safety week, and we have to, so to speak, transport them safely from one destination to the other through the treatment cycle. So this particular voyage of this aircraft, they planned their route, and they had suspected there will be some severe weather when they were doing their second leg of the trip. That was from Douala to Nairobi. So this aircraft lands in Douala about 11 p.m. and offloads some passengers and loads others, such that there are a total of 114, including the crew, 8 crew, and the rest being the passengers. It is being flown by a very experienced captain who has 8,000 flight hours, majority on this Boeing 737, and a very new pilot, co-pilot, or what they call first officer, who has just 10% of the flight hours. So you can see that this age and experience difference, something that happens a lot in our space. You have an intern, a very experienced, maybe consultant or nurse. And so how does safety play out in such a scenario? This will prove to be important, as we shall see later. In fact, from a recording of what they call the black box, you can see they're having a conversation. The first officer is kind of trying to, things are happening very fast. It's raining, there's a storm outside. And the captain is kind of, laughing, asking, are you with it? So just 6 minutes past midnight, they take off into the dark skies of the night. And then something begins to happen. You can see from the picture, the plane is kind of angled. And this is because the pilot had, on this screen, you can see there is something that looks like a weather chart there. He needed to move between the red bits. The red bits are the eye of the storm. And he needed to navigate away from those nimbus clouds. So he's trying to, the triangle there shows the position of the aircraft and how he needs to maneuver. And that's the trajectory that he needs to take. That's why the plane is somehow angled. But as this is happening, there's a bit of confusion in the cockpit, and they actually take off without being granted permission to take off. And the plane has a slight bank, as you have noted. which the pilot manually corrects, then calls out that he has engaged the autopilot. Now, just like we have in the health setting, we have the closed loop communication. If you are resuscitating a patient, for example, and you do an action, then whoever does the action or orders the action to be done will require a feedback that, let's say, if it was adrenaline to be administered, yes, 0.1 per milligram per kilogram has been given, first dose, and so on. So in this case, the co-pilot does not acknowledge this. The aircraft continues banking. So now we're in a situation where the plane is not being flown by the pilot because the pilot thinks he has put in the autopilot. And the plane is not being flown by the autopilot because it is not been engaged. So it continues to roll towards the right. So this is just a picture showing the degrees of how a plane can roll. And this plane was rolling beyond 90 degrees. So it looks like a jet fighter, but now it's a commercial plane. So what happens? It rose to around 15 degrees. The pilot realizes that it is rolling. He tries to correct, but it's too late because when it's rolling so steeply, it actually starts to descend, and the crew go into a panic. And 1 minute 40 seconds into the journey, the plane actually crashes into the mangrove swamp. That is the story of KQ 570 at Douala, just after taking off from Douala Airport. Now, background check showed us, of course, the experience of the first officer. These pilots, usually they have some, competency assessment, as you can see in the picture there, where there is someone just noting what they are doing. And in one of the competence assessments had been done in the previous year, had noted that for this pilot to be made a captain during the upgrade training, they had noted some character traits like being overbearing, touch of arrogance. Remember, he was even laughing at his co-pilot, telling him, are you with it? Yeah, flight discipline, cockpit scans. No wonder he missed to see that the command autopilot had not been engaged. We have a first officer who also had some small improvements to do. And one of them is assertiveness. And this is one area I wanted to focus as we look at patient safety, assertiveness, because this co-pilot their main job is to shadow the captain, to make sure the captain has done what they're meant to do and to warn them if they have missed a step. But we can see if at all he noticed there are some things amiss, he did not call them out. And the captain was not very encouraging in trying to receive positively areas of concern. So that takes us to what does it mean to have a safety culture? It is that environment we build that helps us to deal with risk within an organization. It is perceptions, it is that I can be told by my junior that I have forgotten to sign for this, I did not double check this drug before administering, that I have not washed my hands before going into the patient care area. In 1986, Chernobyl disaster, we all know this famous power plant in Ukraine that melted. There was a meltdown there. That's where the term safety culture was born. And it was a matter of the team that was investigating this incident called it a set of characteristics and attitudes, very important attitudes, whereby the term safety first that safety is an overriding priority in the work environment, and be able to elevate some issues, deal with them before proceeding. So how do you develop? We need to think like what we call high reliability organizations. Just because you see in the health space, if a patient dies, they get buried and the doctor survives, the nurse survives, the healthcare worker may be a second victim, but oftentimes they survive. Unlike aviation or like we're seeing energy sector, where an accident will actually cost the lives of even the operators. So we need to think like them. Systems approach, allowing people to learn and be taught, that is a just safe, fair and just culture, and then having mindfulness. So just look at systems approach. A system is made of various components. And the danger sometimes is we tend to over-emphasize on people such that they feel, they're kind of gaslighted, or so to speak, they are shamed for the mistakes they make. This leads to less reporting, which means the system will not learn, will not have incident reports and to see the trends. And then we don't go and deal with the real issues. Maybe we just deal with them superficially. So having a fair and just culture means first we reward the ones who are going over and above to do the right thing. But for those who have human error, we first begin by supporting them, training them, and not rushing to punish. Because this way we encourage reporting, and that way we're able to have targeted interventions. Disciplinary action is something that is a last resort. Usually, if someone goes for disciplinary action on their first mistake, that's a red flag. But those who have the habit of, lapses, obviously, that already shows that they don't have that willingness to learn. Then you look at the issue of mindfulness. This is a concept I wanted just to share in this webinar, because especially in high stress environments. So Hayes et al. Says that this is where we're able to either change or persist in what we're doing, depending on the objectives. So we have our feet where we are, and we are put attention in solving problems rather than feeling overwhelmed. This happens a lot in health space. I remember during COVID time, you would feel overburdened, overwhelmed by what is happening, but it can happen anytime. A patient comes who is very causing a scene, they're delayed, the treatment has been delayed, and usually the noisiest patients have the worst outcomes because they cause stress to the health worker. But remember, for the patient to be safe, the health worker has to be far. It has to be safe. We cannot control what the patient does, but we can control how we react to what the patient does. Can we have that mindfulness and separating? To feel stressed there's no problem, but to concentrate on that feeling that's where the problem is. Just like to recognize danger is real, but being afraid is our reaction to danger. We don't need to focus on fear, but rather on how to solve the problem and eliminate the danger. So let us have our feet, be where our feet are not where the stressors are. So this concept of mindfulness has been used, like I've said, in aviation sector. Like you can see, it took less than 2 minutes for such a big aircraft to crash, because they move very fast, so they cover a vast distance in a short time. Even for us in health space, it can take less than a minute to kill a patient if you're using very potent drugs, for example, or you're carrying a very delicate procedure. So to avoid information overload, being aware of the small things that are going wrong, and being able to recall our experience, because we know what panic does to us. Then lastly, the same ideas we can promote to the patient. And here there's this poster from JCI about helping patients to speak up. So as leaders, we need to be mindful and carry out regular rounds to encourage and spread this safety culture. Encourage our staff to have daily, meetups to check for any problems. Safety hurdles are there. They are about identifying risk on a daily basis. We don't just make a risk register and say, yeah, we are done for the year, or until the next quarter when the risk team come and ask us to update our register. No, it's something we look at every day. And then this CQI processes that we are doing, but I want to focus on speaking, assertiveness. Can we help our patients to speak up? We put for them material like this one, where we tell them that they need to point out when things are going wrong. And you can see from there, in the acronym there, it's a very nice acronym. Actually, if you put it in a patient space, they can take time to study it and show that they will participate in their treatment. They can't just assume things are happening correctly. They need to pay attention. They also need to have situational awareness, educate themselves, learn about their disease, ask questions, even ask for support, like have an alibi. We know nurse is a patient advocate, but the other advocates like relatives, yes. And it's very funny, even in this day and age, as a health worker, even if it is your own relative who is admitted. I remember the other day, I had a colleague who had been admitted. The daughter actually had been admitted to a facility, and he was telling me that when he went there, he did not want to rock the boat, so to speak, because he's a doctor. He doesn't want to look like he's Kimbelembele. Otherwise, he'll upset the other doctors and they'll make life difficult for his daughter. So you can imagine, if we as health workers feel like this, what about our patients? So we need to first encourage ourselves to be assertive, encourage ourselves not to feel shamed if a patient is assertive to us or a colleague is assertive to us. And then we promote this culture. So with that, I want to come to the end of the presentation and hand it back to the moderator. Thank you very much.
Thank you very much, Dr. Daniel, for taking us through that presentation. Very well said, and that's a very good example that you gave of the air flight, and mistakes that can happen. They can cost lives. And I think what has touched me most is that when you make a mistake as a pilot, you go down with the plane. But when you make a mistake as a healthcare worker, you are spared. So I think we need to also think beyond that these are lives we are dealing with. So we don't need to be so hard on our patients or also very loose on them, but just to make sure that they are comfortable, because at the end of the day, we are all potential patients. Yeah, each one of us is a potential patient, and we don't want to be in that situation. When you line up somewhere and it's not even a hospital, by the way, you feel so frustrated even as a health worker. So you can imagine when somebody's sick and lining up there, how they feel and how they can behave. So thank you very much for that. I think for those ones who have questions, kindly put them on the chat so that we can be able to engage. Remember, our theme for this year's World Patient Safety Day is engaging patients for patient safety. You cannot do patient safety alone, but you need to engage with the patients. So I think the second part, if I'm not wrong, of this presentation is being given by Dr. Rhoda Kalondu. Am I right, Dr. Kalondu?
No, sorry. Yes, sorry, Eric, I didn't catch.
Hello, Dr. Daniel, yes. Am I on?
Yes, you're on. Hello.
Okay. Dr. Kalondo, you were taking the second part of the presentation?
No. We move on to Stella's presentation.
Okay.
Yes. Sorry about that confusion.
Okay, thank you very much. So let's keep our questions coming. We'll pick them and then we'll have a whole panel of experts trying to respond to them and just share. So at this juncture, we're going to invite Dr. Stella Misheni. Dr. Stella Misheni is a pharmacist and also a health systems specialist and a quality improvement team chairperson. Dr. Stella works at the Nyeri County Referral Hospital, and she's going to be sharing something on enhancing a positive patient experience, one patient, one bed, a case of Nyeri County Referral Hospital. So thank you very much. Dr. Stella, karibu, and take the floor.
Thank you very much for that intro. My name is Stella Misheni from Nyeri CRH. I don't know whether you can see my screen.
Yes, we can see it, but it's not on presentation mode.
Just a moment.
You can go down on your right side. Yeah, then click that one that looks like a TV, just below that. Not there. Okay, come across, like you're coming to the right side on that same row. Okay, you've passed it. Go behind a little bit. Yeah, yes.
Is it there?
You've seen it.
It's all right?
Yes. Yeah, it's all right now. Go ahead.
Thank you. So my presentation is on enhancing positive patient experience, one patient, one bed. This is a case of Nyeri County Referral Hospital. So this is a basic outline of the county. We border 5 counties, that is Laikipia, Meru, Murang'a, Nyandarua, and Kirinyaga. And in terms of our health facilities in the county, we have a total of 418 spread across level 6, level 5, level 4, level 2s and 3, and we have 251 community health units. So our facility is basically a level 5. It's the county referral hospital for Nyeri County. And it is owned by the government, and our catchment population is approximately 111,154, and our bed capacity is 263 beds with 53 cots. So our problem statement, we know sharing of beds in public facilities across the country has been a problem over time. I mean, for a very long period of time. And majorly it is because, as we know in our setup, we are in developing countries, the health-seeking behavior, the number of patients that seek healthcare services, majority of them seek those services from public hospitals. And of course, based on those numbers, then that will mean that you will have a number that will also require admission. And Nyeri County has not been spared from that. And we have had an issue with bed sharing, which with sharing of beds, many issues will come up with along with that, including increased duration of hospital stays. You have hospital-acquired infections, there's an increase in mortality, and obviously the overall is an increased cost in the healthcare costs, or basically, you know, more expenses to the health system. So we had various improvement approaches because before COVID, sharing was still there. One of the approaches was instituted by our hospital infection prevention and control committee, where they came up with a guideline to implement the one patient, one bed kind of policy that was around 2019, but that was not implemented until 2020, when COVID struck, and the ministry issued guidelines to do with social distancing and all those things that came with COVID. So what the hospital did after COVID, we instituted a downward referral mechanism, basically to decongest our wards and ensure that we have one patient, one bed, and the patients were not sharing beds. So as we did the downward referral, we did it to our other level 4 hospitals, which are 4 other hospitals in the county, some faith-based organizations and private hospitals. And of course, that was done in consultation with the patient. We did a lot of sensitization in the wards to the people that were hospitalized, and also to the health workers, to basically explain to them where we need to move them to other facilities, but it is also a facility of their choice based on many factors: ability to pay, are they covered, and all those factors. So the other thing that we did, the county established a referral forum where all matters that concern referral are usually discussed. So what happens in the county is that every day, every morning in that forum, it's a WhatsApp group, every of the 5 hospitals within the county is supposed to share a report on the beds available in each and every of the wards. So that in the event that, for example, a patient is at PGH and we need to refer to another hospital around, perhaps Karatina, then we can check from the report, were there beds available at the male medical ward, for example, and then we're able to do that. If it is not there, we move to the next hospital, to the next, and to the next, until we find a place for that patient. What something else the county did is that they deployed staff to those lower level facilities, and especially specialists. Consultants are also deployed in the low level falls, and basically where we are referring those patients to ensure that the patients are going to receive the services that were sent or they're expected to receive. The other thing is that also before referral, the hospital made sure that all the relevant investigations were done, because you might find there are a couple of those investigations that are not being offered in the lower level facilities. So all of them are done at our hospital, and then the patient is referred with the results for ease of management. We also have a very efficient ambulance command and control center where all ambulances within the county, which is both public and private, have been mapped and the contacts have been provided. So there's a hotline. I will be sharing a few of those photos shortly. A hotline where the patients are supposed to call and perhaps be connected to an ambulance that is available. And then as far as the hospital is concerned, we have one central, admissions desk where we have a coordinator who oversees all those issues, so that we don't have a situation where a patient was referred from a female medical. We have 2 female medical wards, maybe one was referred and another one was referred, and then all of them find themselves in a facility that had 1 bed. So we usually have a central desk with a coordinator who oversees all those referrals, and the same person ensures that an escort is provided for the patient to ensure, again, this proper handover at the facility, at the receiving facility. We also received a lot of support, both from the county and from the facilities we are referring to. They were very supportive in all this. What we noted after that, we had improved patient care. There was closer monitoring of patients, improved privacy, and an overall patient experience, because in this same wards, the staff were the same, both when we had sharing of beds and even later. It's not like when we had maybe 3 times or 2 times the capacity of patients admitted. It was still the same number of staff. So this was subjectively reported by the caregivers in the wards, that at least they are able to give a more personalized and a better care to the patients when there are fewer in the wards. They are able to very fast pick on a patient who is going down or who is deteriorating, as opposed to when you have a very, very crowded ward. The other issue was, or the other benefit was, we have seen a lot of reduction of mortalities in our various inpatients, with that, when we ensured that we have 1 patient, 1 bed. And then we have improved environmental cleanliness. through the ward administrator, the community was engaged to basically, it was an accountability tool that was administered to the community, which is what they're calling the community scorecard. It was administered to the community. So they're supposed to assess the hospital based on 9 criteria. And one of those criteria was cleanliness. And what came out in the report that was shared with the hospital is that the patients are very happy about the cleanliness. They actually said, or rather equated the cleanliness of the hospital to what they find in a private hospital. So in fact, some of the patients were saying, if all the services we were offering here could be equated to how clean the hospital is, then they would be happier with the facility. So this is just an illustration of our bed occupancy. I compared 2 years, 2019, when we were doing, when we had a lot of that sharing of beds, versus 2022. This is post implementation of the 1 bed, 1 patient policy. So as you can see, in 2019, our bed occupancy was above 100%, except for 1 month. The rest of the time, if you look at that line graph, as compared to 2022, where our occupancy has been slightly below 100%. So these are basically photos of, this is the same ward, so that we have on the left, you have before, and on the right, you have after. We instituted the 1 patient, 1 bed policy. As you can see, we had, this is, you know, not very good. You can imagine 3 patients on 1 bed. And this is our antenatal ward. And then after that, you can see what we have currently on our right. So this is these are just snapshots of the referral sharing forum, or what happens. So the hospitals are basically supposed to give a breakdown of the beds available and where they are available. So we have the first one on the left is for Karatina Sub-County Hospital. We have our hospital there. We have Othaya, and we have the other hospital. So even as you refer, you are able to check quickly where beds are available, and then you refer the patient appropriately downwards to those particular facilities. Also, before we refer, the facility also calls to confirm. Perhaps the bed was available at 8 a.m., but then at 4 p.m., it may have been occupied. So there's also that part of confirming. So this is our hotline. This is the ambulance hotline. This number is usually circulated widely within the county. You call, there's that command center, which basically they're able to allocate ambulances for wherever the patient is. So this is just a bar graph of comparing mortalities in our male medical ward. In 2019 versus 2022, we had 342 mortalities in the year 2019 between January to December, as you can see, and then compared to a significantly lower number of mortalities in 2022 at 159. So that is as shown in those bar graphs. The blue is 2019, the red is 2022. This is our maternal mortality, that is comparing the 2 years. So we had 15 in 2019, comparing with 9 in 2022. Representation as shown, the red again is 2022, while the blue is 2019. So the lessons we learned from implementation of the 1 bed 1 policy is, number 1, leadership at all levels is very key in the success of implementation of this 1 patient 1 bed. Like I said, we got a lot of support from the county. Remember also, this issue of beds could have an aspect of politics into it, but really there was a lot of support, political goodwill, and basically, as we preach the gospel of patient safety, offering quality health services. So we received a lot of that support across all levels, both from the county level, even from the lower level facilities where we were referring these patients. The other part is the importance of involving hospital technical committees. There are so many committees that usually support quality in the hospital. We have, for example, IPC, there's the QIT, we have complaints and compliments committee. There are a couple of them, MTCs, AMS, all those committees have been instrumental to the implementation of this, because all those activities generally support patient safety at the end of it. And then the other part is make use of the existing structures. We do not have to reinvent the wheel. We do not have to expand our wards. We did not have to build, a new unit. We just basically made use of what we have. The lower level facilities, we generally, used the resources that are within our reach. And lastly, proper coordination of services across all healthcare facilities to basically improve efficiency. So there's very good coordination between the lower level and the higher or the referral hospitals, but especially the lower level facilities. There has to be a very good coordination also in terms of ambulances, how you coordinate referral, and basically the whole process of ensuring the patient gets the best services that they can get. Yeah, so thank you very much. That is the presentation from Nyeri, and that's the team that was involved in as far as coming up with that, the discussions around it, the people that we engaged. So thank you very much.
Thank you very much, Stella, for that very well said presentation. That's a typical example of homegrown solutions, and I think the listeners on this call coming from the counties, I can see quite a number of clubs coming up. I'm sure they are going to copy some of the initiatives that you've brought up in that discussion about Nyeri County. So thank you very much. I know we have quite a number of panelists in the group. So in case a panelist has a comment, I will allow them to go ahead and raise their hands or request to speak, and then we can give them a chance. But as we do that, as the panelists joined by Murega, Okutoi, Mutanda, and also our well-able Rhoda. Stella, there's a question that came up as you were presenting on the issue of one patient, one bed.
Yes.
Do you do lower facility referral from a higher facility, like, well, let's say from a level 4 to a level 2? And while you are doing that, do you also, what is the consideration you make on treatment options also at the lower levels as you're doing that referral? So as you think about that, if there is any other question or comment from the panelists, you can go ahead and respond to it as we wait for others also to chime in. Over to you, Stella.
Thank you for that question. So yes, we do refer to lower level facilities from, especially from most of our referrals usually are from our hospital level 5 to level 4s. The considerations we make, number one, is of course the condition of the patient, and is the facility we are referring to able to handle that particular patient. Now I can give an example. Sometimes, yes, our hospital is full, but the kind of service the patient requires is a specialized service. For example, let me give an example of dialysis. We perhaps, assuming we have a patient who requires dialysis, and our beds are full in our medical ward. So what we usually do, the patient will be admitted in a lower level facilities, but every morning an ambulance is provided to ferry the patient to PGH for dialysis, and then they are ferried back to their facility for dialysis, for review, and then now they go back to the lower level facility, which usually is a level 4. So the considerations we make are, number one, and majorly, is ensure that if that particular a special service that is required, if it's a specialized service that is required. So if it is not available on site where we are down referring the patient, then the patient will come to PGH. If it's dialysis, for example, it is done and then they go back to the facility. We also consider if other factors, if where we are referring to, for example, if it's an orthopedic case, we have an orthopedic surgeon. If we are referring them to, if it's a pediatric case, where we are referring to, do they require a pediatrician, and is a pediatrician available in that facility? Yeah, so that is what we do. Thank you.
Okay, thank you very much for that. Now, a follow-up question on that. The ambulances, who takes care of the charges of the ambulances? And then you see the way you're describing the whole system, it looks like quite a robust system with the with officers ready to be able to like analyze and evaluate the cases and then refer appropriately. So is there like a referral team made up of specialties and representatives from all the hospitals, or how do you go about it? And then also, how are the ambulances financed? If you could probably respond to that as well. Over to you.
So thank you for the ambulances. The charges is it is the patient who pays for the ambulance, or the charges, the cost of transport from to wherever that is happening. For as far as the referral team is concerned, yes, there's a referral forum that consists of healthcare providers from the hospitals within the county, where they discuss various referral issues, any issue that has to do with referral. So we have, for example, that forum has people from Karatina, has people from Mukurweini, they have people from PGH, from Mount Kenya, from basically all the hospitals that offer, services within. There's also involvement of FBOs and private, where the patients wish to also, be down referred to a lower level facility. For the ambulance, again, I don't know whether the county patient safety coordinator may have more information on the ambulances. I don't know whether he's logged in, Dr. Munywa, perhaps he's logged in. I know he can comment on the ambulances.
Okay, for him to be able to speak, he has to be on the panel, because I'm seeing, yeah, he's not, the panel only has, I think 7
Eric,
people.
to invite him to join the panelists just now.
Oh yes, kindly do that. I know participants are we have over 300, I think, participants. So let's try and see how we can locate him to comment on the ambulances. And as he comes to comment on the ambulances, there's a question here that there could be a chance of engagement of all ambulances at one point. So I think he can also weigh into that as he responds on the issue of ambulances. So have you been able to locate him in the crowd?
Yes, we found it.
Oh, you found Dr. Munywa, eh? Okay. So as Dr. Munywa also comes on board to respond to those questions, there are questions to Dr. Daniel. So I'll just read them. Then as they're thinking about the answers, then Dr. Munywa can respond about the issue of ambulances. So to Dr. Daniel, hospital accreditation, do we have a local entity that does hospital accreditation, or we only have international organizations? So that one is to Dr. Daniel. So Dr. Munywa, karibu sana to the panel, and we are glad that Nyeri is doing a good job. So kindly respond to the issue of ambulances, about the cost, availability, and the coordination. Over to you, Peter Munyo.
So, thank you. Thank you very much for the question. The county does run a number of ambulances at the facility level, that's at hospital level, as well as community level. The community level is where the coordination for referrals that are coming from health centers and dispensaries, they are coordinated and they're referred to hospitals. Each hospital does have an ambulance. The bigger the facilities do operate more than one ambulance, and the ambulances at the hospital level are funded. The ambulances at hospital level are catered for by patients. Patients get a bill for that to wherever they need to be referred to. It could be an upward referral from a level 4 to a level 5 or even to a level 6. And they also cater for the costs if they are being referred downwards. That is catered for, that is done through at the level of billing. It's included as part of the bill, but it's usually affordable. Locally, I think it's around 2,000 shillings, so it's affordable for the patients. Thank you.
Okay, thank you. Thank you very much, Dr. Munyo, for that. Any comment from the panelists before we go to the other questions? Kenyatta Hospital, I know when people talk about referral, we always think of referring to KNH. Now you can see what is happening in Nyeri County. Any comment?
Allow me to give a comment. I think this is very great what is happening in Nyeri. When care in the lower levels are happening well, it means that we get a timely referral and patients are able to access care when they need. So to us, any success at the lower levels is a great plus, and that's why there is emphasis on primary health care. So I like the system approach that Nyeri is taking. That the issue of access and coordination of care is a key marker of access to that service when you want, and the right quality and at the right level. So thank you very much. I think that was a very practical kind of presentation and insights, and we have picked and learned a lot. Where we can help at the referral hospital, we are willing and open to make it easier so that the patients can arrive on time and in a better state. There's a coordination service in KNH, accident and emergency, whereby the referral is the ones referring call, and at times they're given instructions on even pre-hospital care. And so just to appreciate that presentation by Stella and Munyo, the two doctors, we are grateful. Thank you.
Yeah, maybe Eric, I could tackle the question on accreditation.
Hello, Daniel, you wanted me to repeat the question?
No, I wanted to just make an answer to that question.
Kindly go ahead. Kindly go ahead.
Yeah, so the issue of accrediting hospitals for quality is something that is new in Kenya, and we have the Kenya Healthcare Accreditation Framework that was passed in some time in 2020. So this contemplates that KENAS is one that is going to be accrediting these independent conformity assessment bodies, as you can see in the diagram here. So to my knowledge, the only one that has gone through this process with KENAS is actually PharmAccess. And once they get that conformity assessment body accreditation is when they're able to do to perform the health accreditation. So I think it's a process that is ongoing. It is something new. It's less than 3 years in the making. So we hope we'll have more bodies coming up to go through the process with KENAS and be able to accredit. Now, as to which standard, that depends on whichever body that will go for this. We know we have the Kenya Quality Model for Health, so we need people who can do that, go through that process. And then there are also now the ones that the international ones, because even for the international ones, like some hospitals are Joint Commission are accredited. Still, they would need to have this local pass through the local authority so as to be able to carry out these international accreditations like COSASA, JCI, and others. Thank you.
Thank you very much, Dr. Daniel. Okay, just a follow-up question on that. The one that KENAS is doing the local accreditation process, is it stepwise or, that do or die, as in you either passed or you failed? So what kind of a framework are you looking at together with KENAS?
Okay, KENAS looks at the process. It doesn't look at the standard that is going to be used. We are saying when someone becomes a CAB or a conformity assessment body, it means they have the right processes to go and assess an organization and make a determination whether they are meeting standards. So it is the conformity assessment body to tell KENAS which standard they are going to be using. So as I have mentioned, we have many standards. We have our local Kenya Quality Model for Health facilities. We have the international ones, like the South African one, which is the COSASA. We have the Joint Commission. So it is that conformity assessment body to come and say we have the skills, and the specialization. We understand this standard, and then they are now examined by SANAS, and they have to keep up that certification or accreditation to be able to go and assess other bodies. Yeah.
Thank you very much, Dr. Daniel. I can see Dr. Lydia's hand is up. Go ahead, Dr. Oktoi.
Thank you very much. And thank you very much, Peter, for that explanation. So as far as the Kenyan definition is concerned, so KENAS is the only accrediting body. So all those other conformity assessment bodies will be independent of KENAS. So they will be doing certification. So whereas the international standards, for example, we can say Aga Khan is JCI accredited. As far as the Kenyan definition is concerned, it is like Aga Khan has that level of certification. And so the framework for certification and accreditation for healthcare quality invite other third parties. And so whereas PharmAccess have their standards, which is the safe care, other third-party bodies will be welcomed to support the KQMH. So the KQMH becomes the foundation standard for the country. The others become icing on top of the cake. And so that discussion is ongoing with having the frameworks on how these different standards will be accredited, because certification is against a standard. And so the Kenya Quality Model for Health is the Kenyan standard. And whereas we've been told by our Dr. Kura, there's JCI, Safe Care, and COSASA, which are currently in the country, and they're healthcare related certifications. And so they're very applicable. Whereas the KQMH, the revised version, it is now being rolled out. But the conformity assessment bodies are being onboarded to the best of our knowledge. And there is a framework that is being developed currently by the MOH on how now this will be implemented. Thank you.
Thank you very much, Dr. Oktoi. A follow-up on that, probably you could shed more light on the stepwise issue, or it's a yes and no. There is nothing like you are growing up towards you know, accreditation or something like that? How is it? What are you foreseeing, or what's your advice also on that we can know this one is this level of certification? Then are there levels of certification, or it's either or?
Yes, there are levels of certification, even starting with SafeCare, which is a product of Farm Access. It has levels of certification. Similarly, the KQMH has levels of certification, and it has what is called a risk-based approach, whereby there is the bare minimum level of minimum certification. After that, you are given the different stars, and those different stars refer to you adding another aspects of quality. However, the bare minimum is what is the universally accepted minimum level of standards for KQMH. And so it means the levels are specific to each standard. So SafeCare will have its own approach to that stepwise. KQMH has its own approach to the stepwise. So that is specific to the standard. And I'm aware that even JCI, they're even developing it to the extent that they'll be certifying different services. For example, you'll get the renal services in a hospital are accredited by JCI, yet maybe the cardiology are still in the process. So they're trying to divide it so that it becomes agile, that we can develop centers of excellence within a bigger organization, as much as, let's say, the rest of the organization has not fixed it. So the stepwise approach is dependent on the standard. The standard specifies requirements, and it specifies the various aspects to be met. And then also it goes through a process, a scientific process that includes both the evidence that is known and what has worked. And they keep revising even the issues of stepwise. So as far as KQMH is concerned, it is a beginning to the best of my knowledge, but the bare minimum is what is said that if you do not meet it, you either need to be closed or you be, that is before registration. The bare minimum has to be met before now we start getting to improvement, continuous quality improvement. Thank you.
Wow, thank you. Thank you so much, Dr. Choi, for explaining that one and unpackaging for our understanding. So any other comment from the panelists? Any panelists with a comment? Okay, so other questions that were coming up, most of them are on CPD, award of the CPD points. And I'm thinking Dr. Kalondu probably will be able to talk into that, because that's not my area. I've seen quite a number of people. They are wondering either how to get their CPD points or they did not get their CPD points, and how can they follow up and get their CPD points. So that one I will push it to Dr. Rhoda Kalondu. The others is just to appreciate. Quite a number of people have appreciated what Nyeri County is doing. And Nyeri County, congratulations to many people. I'm sure the claps and the loves that are flying are towards the Nyeri County. So congratulations for that. You've done a good job and other people can learn from it. So this time, just to remind you, our World Patient Safety Day is on 17th. Yeah, we are going to have a walk from the MOH round and finish up at the Pan-Africa Hotel, where we are going to take tea and lunch, and also have a few people speak here and there. So I think you are all invited for that. The ones in the counties, I'm sure each and every county will also be celebrating this big day. So everybody, again, within the counties, you know, muscle up your teams and celebrate the big day. So at this juncture, I'll take it back to Dr. Rhoda Kalondu, probably to give us I don't know whether Thomas joined, Thomas Gashuki from Ministry of Health, to give a vote of thanks on behalf of the ministry. If he has, then Dr. Kalondu, you can invite him. But from me, it is back to you, Dr. Rhoda, for the closure. Asanteni sana.
Okay, thank you very much, Eric. And thank you very much, Dr. Daniel and Dr. Stella, for your wonderful presentations. Dr. Stella, thank you for that practical approach. And I like what you said, using existing structures and existing resources to create improvement. So thank you very much, Nyeri County, for that initiative. It's a practical one, and I think it's something that can be scaled up and adopted by many other facilities in this webinar. I've not yet seen Dr. Thomas Gashuki, and we were hoping at least he'd have the remaining time. So now that he's not here, maybe we could hear from Nyeri County. What are your plans for World Patient Safety Day as we wind up this webinar? Dr. Stella, are there any plans for World Patient Safety Day at Nyeri County and any other county that is represented here or an organization? Just raise your hand and we'll let you share with us what you're planning to do in your facility, in your county, in your organization with regards to World Patient Safety Day.
Sorry, Dr. Rhoda, I think Jennifer has just clarified there. Actually, the walk will be on Friday, Friday 15th. Okay. Yes, on Friday 15th. World Patient Safety Day is on 17th, but the walk, the one that we are working from the Ministry of Health down to Pan-African Hotel will be on Friday the 15th. Thank you very much, Jennifer, for that clarification. Over to you, Dr. Rhoda.
All right, thank you. So Stella or Dr. Munywa, maybe you could just share what plans you have.
Yes.
Yes.
Yes, thank you. So we will commemorate Patient Safety Day in Nyeri County on the 18th, which is Monday. We've lined up, we are planning together with KNH Othaya or the Mwai Kibaki Hospital, so that on that day we will have a series of presentations on patient safety, sort of a training from morning up to around 2 p.m. Various speakers have been lined up, both from the county and from KNH and from our partners around, including Farm Access and AMREF and CDC. So it will be a physical activity in at Mwai Kibaki Referral Hospital. And those around Nyeri are invited to join us.
Thank you. That sounds very exciting. And we look forward to seeing at least some live footage or some messaging on social media platforms with regards to that. And we wish you success in your planning and in the events that you intend to carry out on that 18th of September. David Odwar, would you like to maybe just share your facility where you work or your county and the plans that you have in place for that? I'm seeing concerns about CPD points, and I think some have been responded to. So let's wait for David to share. Yes, okay. Collins is asking if they can be reminded of the walk at day 2, so as to keep the communities engaged. Yes, Collins, so the walk will be this coming Friday, 15th of September. From, as Erica said, from Ministry of Health, Apia House. There's an old route, our old circuit that will be walking up to the place where we'll be having the conference, the World Patient Safety Day conference. That is at Saropa Pan-African. And we look forward to your virtual participation. I can see you're saying you work within Kisumu County. If you're able to make it, that will be good. Failure to reach, we look forward to your virtual participation. So we look forward to sharing the link for those who will not be able to physically attend the sessions. About CPD points, I will forward these concerns to the team that manages CPD points. And I can see there are quite a number of them, especially PPB. With relation to PPB, some have been responded to already, but others are still pending. So we look forward to having quick resolution to your CPD. I'm also just requesting for patience. I've seen that somebody who said they attended yesterday and they are looking for their CPD points. So we kindly request for your patience. As you can see on today's platform, we have a total of 1,000, well, it was 1,500 and something. Now we're at 1,400 400 and something. So by the time you reach out to all those people, ensure they all have their tokens. And remember, we are from different cadres, different disciplines. There's a pharmacist, there's the clinical officers, there's nurses, there's doctors, there's dentists, and we're all coming from different regulatory bodies. It takes a bit of time to assess, analyze, filter, and send the corrections to the correct teams. Those who need theirs on email, to send them on email. Those ones which you upload directly to their portal, to upload them directly to their portal. So we request for your patience. So I don't know, maybe we still request for your patience in this issue, especially if you've been attending, if you attended yesterday, or if you attend today, we are yet to find a system that gives you automatically your CPD at the end of this session. For those who have more concerns, I've seen there's somebody who said they've attended 15 sessions and they've only gotten 2 CPD points. We'd like to follow up on this. And I can see the response was that there's a delay for PPB. So we'll follow up on this and see what is causing this delay. But thank you very much for all your comments and the feedback on CPD. We understand it's something that is a pain point for some members, and therefore we look forward to resolving it in a fast manner. Previous webinar recordings, yes, you can access them on YouTube, KNH Research. You'll find them there. The page is KNH Research on YouTube. You'll be able to access the previous webinar recordings. Yes, good job, Dr. Stella, Dr. Kibiria, Dr. Munywa, and the rest of the team that was represented in the last slide. For Stella, good job for that. You've done quite great as Nyeri County, and we appreciate you on that aspect. Trans Nzoia County, I can see you're celebrating your Patient Safety Day on Thursday, 21st. Good job, Faith, and we look forward to seeing more about what you did. You could share what you're doing with the Ministry of Health, and we'll be able to appreciate what every county is doing, and we should be able to learn from each other. Maybe what we're doing this year, we could do different next year. So it gives us an opportunity to learn from each other. I'd like to thank all of you for attending this webinar. Thank you for your time. Thank you for your patience. Thank you for your understanding. Faith from Machakos, level 5, you did a CME today and you'll be celebrating the day tomorrow. Good job, Faith. We are happy to see that the seed of patient safety is not just at the ministry level, but the counties are actively doing this and taking that initiative to the self-drive to celebrate this day and to mark it, not just to celebrate, but to implement these patient safety initiatives that they intend to come into fruition. So we thank you very much for that active participation, and we thank you for joining in this. So I'd like to thank all of you and invite you to the World Patient Safety Day celebrations on Friday. You could join us in spirit and wish us well as we walk. Wish us fantastic weather. If you're outside Nairobi, if you're within Nairobi, you could come walk with us. It starts at 7:30 in the morning, and hopefully it's around 1 hour walk or less, but we look forward to your presence and you joining us. Asanteni sana, do have a good afternoon, and we wish you a safe evening. All right, thank you and bye. Thank you, Eric. Thank you, Dr. Stella. Thank you, Dr. Kura. Thank you to Peter Mtanda and Dr. Mulongo for organizing this session. And thank you also, Dr. Peter Munywa, for stepping in and Dr. Lydia Okutoi for stepping in. Asanteni sana. Do have a good evening. Bye.